Hello everyone, welcome back and thank you for tuning in. I'm excited to talk about a topic that often doesn't receive the recognition it deserves. Genitourinary Syndrome of Menopause, or GSM. The term GSM was introduced in 2014 to replace older terms like vulval vaginal atrophy, atrophic vaginitis, and urogenital atrophy. I completely support the shift to a more neutral terminology, as we wouldn't use terms like testicular or penile atrophy to describe age-related changes in men. This change helps foster a more respectful and accurate understanding of women's health during menopause. Did you know that GSM affects 40 to 90% of perimenopausal women? The prevalence of moderate to severe symptoms serious enough to impact quality of life can vary widely, generally ranging between 30 to 70%. That's a significant number. Yet, it is under-recognized and undertreated. So what exactly is GSM? GSM is a chronic and progressive condition that impacts the vulval vaginal area, sexual function, and the lower urinary tract. It includes a variety of signs and symptoms, primarily linked to the decrease in estrogen levels that occurs during menopause. While GSM mainly affects postmenopausal women, it can also be seen in women who are in premenopause. The low estrogen levels lead to significant hormonal and anatomical changes in the genital urinary tract. Amongst the most common and concerning symptoms are vaginal dryness, dyspareunia or painful intercourse, and reduced lubrication. These symptoms can significantly affect the quality of life for women, especially those who are sexually active. Symptoms involving the bladder and lower urinary tract include urinary urgency, incontinence, dysuria or painful urination, and frequent urinary tract infections. Experiences may also include loss of libido, lack of arousal, and orgasm. Symptoms are varied, with some women experiencing more than one symptom, requiring an individualized approach. Risk factors for GSM include: number 1, women who had early menopause or surgical menopause. Number 2, women who had cancer treatments including pelvic irradiation, chemotherapy, and endocrine therapy. Number 3, smoking and alcohol use. Number 4, medical conditions including hypothalamic amenorrhea or loss of cycles due to stress, undereating, or excessive exercise. So what impact does this have on the quality of life? In a 2013 survey of over 3,000 American women with menopausal GSM, 85% of partnered women reported some loss of intimacy. 59% indicated that their symptoms detracted from enjoyment of sex. 47% indicated interference with their relationship. 29% reported a negative effect on sleep. 27% reported a negative effect on their general enjoyment of life. Here's an important note: Asian women also experience GSM and other menopausal symptoms. Still, even back in 2024, I've had people tell me they still believe that menopause does not affect Asian women. If you're one of them, please educate yourself and watch this video, and help me stop the unconscious micro-invalidations that still exist in women's health. Now back to the facts. GSM is also prevalent among Asian women, with symptoms such as vaginal dryness, irritation, and reduced sexual desire reported, with differences across regions. Also note, the Asian population is ethnically heterogeneous. Among Japanese women aged 40 and older, the prevalence of GSM with genital or sexual symptoms is 11.6%, rising to 31.7% among sexually active women. The prevalence of GSM among Thai postmenopausal women is notably higher at 87.2%, with common symptoms including nocturia or nighttime urination and vaginal dryness. A Pan-Asia survey conducted across Indonesia, Malaysia, Singapore, Taiwan, and Thailand found that 35% of postmenopausal women were aware of GSM, with vaginal dryness and irritation being the most frequently reported symptoms. In Chinese women of midlife, the prevalence of GSM is 30.8%, with decreased sexual desire being the most prevalent symptom. Societal perceptions regarding women's sexuality in older age are predominantly negative, leading many women to view sexual problems as a natural aspect of aging. This mindset causes many women to hesitate in seeking help for their symptoms, resulting in a significant healthcare gap. Several factors contribute to this reluctance, including feelings of shyness or embarrassment when discussing symptoms with healthcare professionals, especially if the provider is a young male, if they've had negative past experiences, or if they believe their symptoms are something to endure. Women may also wait for healthcare providers to address these issues, while providers may hesitate to ask about sexual function. They might dismiss symptoms as typical of aging or feel pressured for time. Additionally, some providers may be unaware of available treatments or their proper dosages, leading to inadequate management of these concerns. That's why it's crucial for healthcare professionals to feel comfortable discussing these topics and to find effective ways to initiate these important conversations. So how is GSM diagnosed? A careful history of symptoms such as its onset, type, duration, and severity are important. An examination may be indicated to rule out specific conditions and potential diagnoses, such as chronic pelvic pain, malignancy, or autoimmune disorders. It's essential to investigate postmenopausal bleeding to rule out gynecological cancer. If there is vaginal discharge or inflammation of the vulva, a vaginal or vulval swab may be taken to check for infection. In cases where the results are concerning or don't improve with prescribed treatments, a vulval biopsy might be necessary. Additionally, urine tests may be required if symptoms are related to bladder issues. What treatments are available for GSM? The main goal is to alleviate symptoms. First-line options typically include non-hormonal therapies such as lubricants and moisturizers. Hormonal therapy using local estrogen products is often considered the gold standard for treatment, available in forms such as creams or peseries. Additionally, newer formulations using the hormone dihydroepiandrosterone or DHEA have also been approved. Other treatments such as selective estrogen receptor modulators or SERMs are available in some countries. Emerging treatments such as laser technologies offer alternative options, especially in women who have breast cancer or do not want hormone therapy. However, further research is needed to evaluate their effectiveness and practical application. I will delve into more depth about medical therapies for GSM and treatment options for women with breast cancer or are at a high risk in another video. Managing sexual function in women may involve addressing issues such as loss of libido and dyspareunia due to pelvic floor or vaginal changes. This requires a thoughtful, team-based approach. Did you know that a pelvic floor physiotherapist can assist with pelvic floor dysfunction, pelvic pain, or urinary symptoms by providing assessments, pelvic floor training, and relaxation techniques? In some cases, supervised use of vaginal dilators may also help. Also important to review any medications such as antidepressants that might impact sexual function. But don't stop taking regular medicines without first consulting your healthcare provider. Additionally, seeking the guidance of a sexual therapist or considering couples counseling may prove beneficial. You may find some validated screening questionnaires helpful in starting the conversation. The day-to-day impact of vaginal aging, or DIVA questionnaire, is available in the link below. Additionally, the Female Sexual Function Index, or FSFI, is a widely used tool available in Malay, Chinese, and Thai versions with a scoring and grading system that identifies mild, moderate, and severe symptoms used in both clinical practice and in research to understand and address female sexual health issues. Thanks for tuning in. If you found this video helpful, please like, comment, subscribe, and hit the notification bell for future updates. Until next time.